All right. Hello, everybody. This is our October 2023 South Dakota Project First Line office hours. This month, we're covering microbial resistance. So let's jump into it. So I'm Jamie Rogenbauer. I've got a background in public health, and I've also been an EMT for about 14 years, first through the Army and then as a civilian. And joining me, my co-host is Jess, and I'll let her introduce herself real quick.
Hello, everyone. Jess Danko. You've probably seen me a million times. My background's healthcare administration. I'm also a registered respiratory therapist and certified in infection prevention for the long-term care setting. Thanks for being here today.
I didn't say no.
Thanks, Jess. So we are both from the South Dakota Foundation for Medical Care, but South Dakota Project First Line was first a collaboration between the CDC and the Department of Health. It was created right around COVID to really bring that training to our frontline healthcare workers. But since then, it's just been a further development of these great training resources on our various topics for infection control. So we're glad you guys are all here with us today. And this is a link to our website, just some really great resources for you guys. It's things that you can learn from, but also that you can use for training for your own space. It includes posters, educational tools, and interactive games. So check out our website. It's going to be a great resource. And then we also included this link to recognizing risk in healthcare. It's also just another great resource for learning and training. Okay, our topic of discussion, microbial resistance. It is one of our greatest public health challenges of our time, and really very few treatment options exist for people who are infected. So every single person makes a difference in preventing resistance from happening, but also from preventing that spread. And really what it is bacteria changes over time. It's a response to those interactions with medications, making those associated infections just more difficult to treat. So what can we do? Infection control fights resistance by preventing new healthcare associated infection. So the goal is to avoid it. This is our upstream battle to prevent these kind of superbugs from ever developing. This is the easiest way to do it is before they even happen. And so upstream is our goal. But another way infection control fights resistance is by stopping the spread of resistant germs. So we know that these antimicrobial resistant AMRs already exist. We can also mitigate it by stopping the spread of it. So this is our downstream approach. It's a little bit more difficult to do this approach, but it's just another way where we can help reduce that spread. And infection control fights resistance by reducing the need for antibiotics or antifungals. We also know a major cause of AMR is inappropriate antibiotic prescriptions, and this is especially true for our respiratory tract infections. We know that antibiotics only work on bacteria that cause infections and not those that are caused by viruses. That's like our flu or our common cold. So if we focus on prescribing antibiotics only when it's medically necessary, that eliminates a huge pathway to the development of antimicrobial resistance. Okay, when you can practice infection control when entering the body, spreading to people, moving with patients, spreading to the community. So good hand hygiene, making sure our surfaces are clean, and then just making sure when we're out in public, we're wearing masks when it's appropriate, and just, again, having good hygiene. All right, the threat of antibiotic resistance in the United States. I'm going to read the slide because it's a good one. Antibiotic resistance, when germs, bacteria, or fungi develop the ability to defeat antibiotics designed to kill them, is one of the greatest global health challenges of modern time. And here's a new national estimate. Each year, antibiotic-resistant bacteria and fungi cause at least an estimated 2,868,700 infections and just under 36,000 deaths. If we look at C. diff, which is related to antibiotic use and antibiotic resistance, we're looking at 223,900 cases and just under 13,000 deaths. So a huge impact from this antibiotic resistance. Antibiotics are among the most frequently prescribed medications in nursing homes. Up to 70% of residents receive one or more courses of it for systemic antibiotics, and studies have shown that 40 to 75% of it is just unnecessary or inappropriate. And so that kind of goes back to, remember, we're prescribing these antibiotics for infections that are appropriate, not for things like viruses and things like that. So we can do a lot to prevent it. And I'll hand it over to Jess now.
All right, thank you, Jamie. That was a lot of great information. Really, when we talk about antibiotics, and those of you that are on this call today, we know a big topic is antibiotic stewardship, both for the hospital setting and the long-term care setting. One thing I want to point out between the two, they really have the same core elements, other than a little bit of change in that pharmacy expertise piece. Hospitals a lot of times have that pharmacist right on staff, so they're able to really utilize their internal staff for the purpose of really promoting, looking at best practices, and understanding the antibiotics that are being used. Whereas long-term care facilities aren't always that fortunate, and sometimes they have to turn to what the core elements refer to as that drug expertise. So we'll talk a little bit more about that as we go through. Other than that, the core elements for both types of setting for the healthcare are very, very similar in the processes that need to be followed, steps that need to be taken, really to establish a great antibiotic stewardship program for your healthcare facility. Next slide, please. So the first one is really looking at leadership commitment, both on the hospital side and the long-term care side. So what does that mean? That means making sure your board is involved, you have your CEOs, your CNOs, and really a champion within that leadership team that's going to report back to that leadership team that really speaks to the importance of the antibiotic stewardship program. On top of that, what we need to look at is we really need to look at how do we show the community, how do we show the staff, how do we show the individuals that are entering our facility that there is a leadership commitment to this. So that might be things such as written statements that as an organization you put out for your support of antibiotic stewardship, and really providing that sense of, yep, this is going to be a culture change. The entire organization is on board with this, all the way from our uppermost leaders to people that just work or come into your facility for day to day. Let's go to the next slide there. The second one is that accountability piece. I kind of touched on this, having that champion within your facility that's really going to take this antibiotic stewardship, make it their own, but then be accountable for reporting it, making sure it's happening, holding each area of healthcare up to the standard that we are wanting to see to be able to achieve great antibiotic stewardship. This can be anyone from maybe a physician, it could be your pharmacist, your IP, anybody within your organization that really is going to hone in on the stewardship, make it be something that they are basically proud of, and really work to make their own and adapt for your facility. Also, with that accountability piece, something that we're seeing as we tour throughout the state, and that really, really helps to make sure this happens, is that it's built into a job description. So it's not just that, oh, you're going to get assigned this duty of being the head of antibiotic stewardship, you're going to be our champion. That doesn't always work. When they are held to the level that, you know what, this is really part of the job and work we expect from you, that accountability piece comes into play and is followed through on a whole lot more concise and consistently, let's say. Next slide, please. So here is where I talked about the difference between that long-term care piece and the hospital side of it. And maybe even some of the very rural hospitals that maybe don't have a pharmacist on staff have to use a pharmacy expert or a consultant. And those are okay. Those can be part of your core elements if you're not able to in-house staff that pharmacist. If they're the ones that are overseeing the antibiotics, and looking at them, getting them ready, set up, those type of things, that absolutely can be somebody that's not in-house for you, the smaller like critical access hospitals. And then the long-term care setting where typically there may not be a pharmacist directly at the facility or on staff. Really with that, the role is very, very similar. It is really just to be that empowered person that's going to look at our meds, make sure they're appropriate for the illness that we're prescribing them for, look at interactions, those type of things. However, that doesn't always have to be a pharmacist too. This can be a code job that maybe we're going to distribute. Of course, the pharmacist is the top line for that, but that's also something that maybe we can assign to some other highly qualified people within our organization, especially when we don't have access to that pharmacist 24 hours a day within our facility. Next slide, please. So then the next part of the core elements is that action piece. So what are we going to do to improve those outcomes, to make sure that everybody's on board, to make sure we reach those maybe targets that we're striving for to reduce the use of unneeded antibiotics? So really there has to be a process in place. This probably is going to involve some procedure changes, some policy changes, those type of interventions that are really going to hone on into everybody has to follow this, from nursing to pharmacists, and we're bring this to our physicians to make sure that we all understand what it is we're doing, how we're doing it, and why we feel it's so important to implement within our facility. Then comes the next piece of those core elements, that tracking piece. If we just say we're going to do this, yep, we have support, but we're not tracking our numbers. We're not looking at if the antibiotic use has changed, what we're using the antibiotics for, those type of things. We really are doing a disservice to implementing an antibiotic stewardship program. This is something that should be continually on a report, a monthly report that maybe gets shared at quality, gets shared at the med staff meetings, that gets shared at our board meetings. This tracking is a crucial piece so everyone knows that we implemented it. These were the steps we took. We're following those steps, and now these are the outcomes we're seeing. Without there being outcomes that can be seen, there's not going to be continued buy-in from anybody, from your physician on down through your staff. Next slide, please. And I already talked about that tracking and then the reporting, they go hand in hand. Those work together. I said they have to be part of a report that's shared out. If we are not doing that, to get everybody involved, to get everybody on board, and to know that this is a process that really is going to be influential within our organization, becomes a problem. And when I'm saying everybody, and I think it even mentions it in here, yep, even the lab. So your nurses, your lab, your infection control people, anyone within your department that's going to play a role in antibiotic stewardship as far as helping to reduce those unneeded antibiotics or prescriptions that are given. And next slide. The education piece is that last piece of the core elements. And this can be one of those key pieces for the antibiotic stewardship program. The reason I say that is, yes, you have to educate those that work within our facility, and they have to know absolutely why we're doing this, why it's important, what's expected of them to be able to participate and be an active member of our stewardship program. But the other component of this is the patient has to understand why we're following the processes that we are, whether that's an inpatient in a hospital facility that we start on IV antibiotics. We do the evaluation, which is usually recommended at about that 2-day or 48-hour process. And maybe at that point we determine, you know what, we've got cultures back. We can absolutely say that it's covered by X medication. We can back off the antibiotics that are given intravenously, and add in oral antibiotics or switch to those oral antibiotics. So making sure the patient understands, yep, maybe you're still in the hospital right now, but you're having oral antibiotics and why we're doing it. And then there's this other piece of the patient care, and that's the families. They are a huge piece of the antibiotic stewardship program as well. For one, why I say that, living in South Dakota in a rural community, it can be very easy to know that, you know what, my provider's my friend and I have the sniffle, so I'm going to call them and say, hey, can I get antibiotics for this? That's a practice that used to happen and maybe still does. But the reality is we should only be treating those bacterial confirmed infections. But also if they have a family member has a patient or a patient is of the family member is in the facility and they don't understand why we're quickly changing from IV antibiotics to orals. Or from the long-term care side, this can be a big thing. And I see this happening as Sherry and I travel the state and do the ICARs, is we're at a facility and it's brought to the nurse's attention by a family member that, oh, my mom's acting kind of funny today. I think she has a UTI. Can we call the doctor? That's not a process that should continue to be happening. We really need to look at our processes and educate that family member that, you know, we need to make sure that we confirm that if we're going to confirm that there is an illness that needs to be treated, and then really, what are the symptoms that are going along with it that are recognized? And are those symptoms that would really signify a UTI? So just really making sure that family also understands we just can't continually treat an ongoing symptom that you think might signify a UTI. And they might not understand that some people are even colonized with things that would indicate that, yes, there's an ongoing UTI that maybe we shouldn't be treating with antibiotics. All right, next slide. So the CDC has some fantastic resources out there. I did drop these links in the chat, but what it provides you is information on each one of those core elements, pieces of the core elements and things that you can implement. And then there's also a checklist available that you can utilize to see if you're using these within your facility. And if you're not, these are things that can be signals to you of what to implement. Next slide. Okay, so part of the antibiotic stewardship program is really that reporting piece. I kind of touched on it earlier. For hospital facilities, it is going to become part of a requirement in 2024 that you have to start reporting this into NHSN. One of the things that CDC is really working on right now is to get the education out there on how this is going to happen, what it looks like, those type of things. Through our work with the South Dakota Foundation for Medical Care, we work with many of the IHS facilities. The first training that's going to be available for South Dakota, it will be IHS facilities, but if you're interested in joining, you absolutely can. Is this training is going to be at the end of the month, October 31st. It's really open to anyone to listen into. I will put the registration code in the chat so you have access to it. However, the same expert that's going to provide this education from the CDC has agreed to do a South Dakota training. We are just setting the dates for that now. So that also will be an option for you if you can't attend this one or you want something that maybe might not include the elements that the IHSs are going to have to utilize within their facilities. We do have an upcoming training for the state of South Dakota that will go out through the South Dakota listservs. If you want to be notified, you can absolutely reach out to us through the Project First Line webpage and to just hit that contact us button, and you can send us a note to please notify you if you're interested in attending the training. All right, next slide. All right, so that kind of brings us to the end of our presentation part of the office hours. Our office hours are really an open format for those of you attending the call to ask any questions that you might have, to talk about processes that you're utilizing, anything like that. So if anybody has any questions or comments, you absolutely can come off of mute at this point and share, or put those questions in chat. Sometimes we learn best from just hearing what each other's doing and processes that are utilized. If nobody has any questions, we'll go ahead and wrap up today's call, and thank you again for joining us.
Thanks, everybody.